Welcome to our video on chronic kidney disease. After watching this video on chronic kidney disease or CKD, you should be able to discuss the definition and staging of CKD, strategies to slow down CKD progression, CKD complications, and kidney replacement options. You should also be able to recognize and stage CKD, provide therapeutic options to slow down CKD progression, and manage CKD complications. Chronic kidney disease or CKD is defined as having kidney damage for 3 months or more due to structural abnormalities with or without reduced glomerular filtration rate, or having functional abnormalities where the glomerular filtration rate falls to below 60 with or without structural damage for 3 months or more. Structural damage may be defined as having pathological abnormalities or markers of kidney damage, such as abnormal composition of blood or urine or imaging tests. Functional abnormalities without structural damage may be seen in patients with reduced glomerular filtration due to reduced cardiac output due to any cardiac pathology or severe renal vasoconstriction associated with hepatorenal syndrome. CKD is staged based on estimated glomerular filtration rate or GFR. Stage 0 applies to individuals who have risk factors for developing CKD but not yet have CKD. Examples of risk factors for CKD include older age or having hypertension, diabetes mellitus, or family history of kidney disease. Patients with kidney damage but still with GFR of 90 or greater are staged as CKD stage 1, denoted as CKD G1, where G is for GFR. Stage 2 is for GFR between 60 and 89. Stage 3A is GFR between 45 and 59. Stage 3B is GFR between 30 and 44. Stage 4 is GFR between 15 and 29. And stage 5 is GFR less than 15. Each CKD stage may also be further categorized based on the severity of albuminuria. The extent of albuminuria is used as a marker for the degree of glomerular basement membrane injury. Albuminuria may be classified as A1 denotes having normal to mildly increased albuminuria. Albumin excretion rate or AER is less than 30 milligrams per 24 hours, or albumin to creatinine ratio ACR less than 30 milligrams of albumin per gram of creatinine. A2 denotes moderate albuminuria, where AER ranges from 30 to 300 milligrams per 24-hour urine collection, or ACR ranges from 30 to 300 milligrams per gram. A3 denotes moderate to severe albuminuria, where AER is greater than 300 milligrams per 24 hours, or ACR greater than 300 milligrams per gram of creatinine. Example: a patient with an estimated GFR or eGFR of 47 and an ACR of 356 milligrams of albumin per gram of creatinine may be denoted as having CKD stage G3A, A3. One of the key reasons for staging CKD is to provide guidance for clinical management. For patients at increased CKD risk, early screening for CKD and CKD risk reduction, such as blood pressure control and/or control of blood glucose in patients with diabetes mellitus, are indicated. For all CKD stages, we need to treat comorbid conditions, work on slowing CKD progression, and reduce cardiovascular risk factors. At earlier stages of CKD, we can evaluate and treat all factors that may contribute to rapid CKD progression. At stages 3A and 3B, we can assess and treat complications associated with CKD. At stage 4, preparation for kidney replacement therapy may be started. Patients are given education regarding the different kidney replacement modalities. Referral for kidney transplant evaluation may be considered ineligible candidates. By stage 5, patients may be placed on kidney replacement therapy such as dialysis or kidney transplantation. The goals in managing patients with CKD include slowing CKD progression, management of CKD complications, and appropriate referral for kidney replacement therapy. So let's now start with how we can slow down CKD progression. Interventions that have been shown to slow CKD progression include the following. The use of renin-angiotensin-aldosterone system inhibitors or RAS inhibitors. The renoprotective effects of angiotensin-converting enzyme inhibitors and angiotensin receptor blockers have been shown to be beyond those of blood pressure control. RAS inhibitors can reduce glomerular filtration pressure, thereby lowering both glomerular injury and proteinuria. Blood pressure control to reduce glomerular endothelial injury. Blood pressure control should be individualized based on comorbidities and degree of albuminuria. The preferential selection of a RAS inhibitor over other antihypertensives may be considered in patients with CKD and albuminuria. Reduction of proteinuria. Proteinuria can be pro-inflammatory and has been shown to correlate with more rapid decline in kidney function. The use of RAS inhibitors has been shown to reduce proteinuria and slow CKD progression. Glycemia control in patients with diabetes mellitus. KDOQI guidelines suggest targeting a hemoglobin A1C of approximately 7% if safely tolerated to prevent or delay progression of microvascular complications of diabetes, including diabetic kidney disease. Of note, in addition to controlling glycemia, the use of sodium glucose transporter 2 inhibitors or SGLT2 inhibitors, including empagliflozin and dapagliflozin, and glucagon-like peptide 1 analogs, including liraglutide and semaglutide, have been shown to reduce macroalbuminuria and slow CKD progression. Correction of metabolic acidosis. Metabolic acidosis generally occurs when the GFR falls below 30. Metabolic acidosis is associated with increased muscle breakdown and bone lysis and accelerated CKD progression. Alkalinization with oral sodium bicarbonate to maintain serum bicarbonate closer to 24 millimoles per liter is recommended. Finally, it is prudent to remind patients with CKD to avoid the use of non-steroidal anti-inflammatory drugs because these drugs can significantly reduce glomerular filtration and promote renal ischemia and injury in patients with CKD. In summary, medical interventions to slow CKD progression include the use of RAS inhibitors, blood pressure control, proteinuria reduction, blood glucose control in patients with diabetes mellitus, correction of metabolic acidosis, and avoidance of NSAIDs use. In addition to slowing CKD progression, we also have to simultaneously manage CKD complications. CKD can adversely affect essentially every organ system. CKD can lead to increased risk for diseases of the cardiovascular system, bones and mineral disorders, anemia and bleeding diathesis or problems with normal coagulation, acquired cystic kidney diseases and renal cell carcinoma, depression, and malnutrition. Starting with cardiovascular diseases. Patients with CKD stages 3 to 4 have double to triple cardiovascular mortality risk. Risk for cardiovascular diseases involve non-traditional risk, including elevated serum phosphate and C-reactive protein levels, hypoalbuminemia, and dialysis vintage. Traditional risks such as hyperlipidemia and blood pressure may not predict outcomes in dialysis patients. Patients with angina may present with minimal or atypical symptoms such as dyspnea and fatigue instead of chest, arm, shoulder, or jaw pain. In adults 50 years or older with CKD and eGFR greater than or equal to 60, treatment with a statin is recommended. Treatment with a statin or statin-ezetimibe combination is recommended if the eGFR is less than 60, regardless of lipid profile. In adults aged 18 to 49 with CKD, treatment with a statin is suggested for those with one or more of the following: known coronary artery disease, diabetes mellitus, prior ischemic stroke, or estimated 10-year incidence of coronary death or non-fatal myocardial infarction that is greater than 10%. In adults with dialysis-dependent CKD, it is suggested that initiation of statins or statin-ezetimibe combination not be done due to the lack of benefit, yet there may be a potential for complications associated with statin use. In patients already receiving statins or statin-ezetimibe combination at the time of dialysis initiation, continuation of these agents is suggested. CKD is associated with mineral and bone disorders, commonly referred to as CKD-MBD. CKD-MBD refers to disorders of systemic mineral metabolism involving abnormalities in biochemical profile, bone turnover, mineralization, and volume, and/or vascular and soft tissue calcifications. Biochemical profile refers to serum calcium, phosphate, bone-specific alkaline phosphatase, and parathyroid hormone. If not promptly recognized and treated, CKD-MBD may result in arterial calcification, pulmonary calcification, periarticular calcification, bone erosions associated with secondary hyperparathyroidism, shown here as subperiosteal erosions, and calcific uremic arteriolopathy, a condition characterized by systemic medial calcification of arterioles and painful ischemic necrosis of skin and subcutaneous tissues. This condition is associated with high morbidity and mortality, with mortality up to 45 to 80% within 1 year. CKD-MBD may present with bone disorders that can range from high turnover bone disease, known as osteitis fibrosa, a condition associated with untreated or uncontrolled secondary hyperparathyroidism associated with CKD, adynamic bone disease, a condition associated with oversuppression of secondary hyperparathyroidism with excess use of vitamin D receptor agonists or calcimimetics, or osteomalacia due to poor bone mineralization that may be seen with hypocalcemia or aluminum toxicity associated with chronic use of aluminum-containing medications. Some patients with CKD may present with mixed bone lesions. Anemia is a major complication of CKD. Anemia associated with CKD is a hyperproliferative, normochromic, normocytic anemia that typically occurs at CKD G3A for males and G3B for females. Anemia is associated with fatigue, poor quality of life, difficulty with concentration, impaired judgment, left ventricular hypertrophy, impaired immune response, and platelet dysfunction, among others. Additionally, anemia is a risk multiplier for mortality in patients with CKD. The pathogenesis of anemia of CKD is multifactorial and include reduced erythropoietin production by peritubular interstitial fibroblasts due to the inflammatory state and loss of kidney mass in CKD, relative resistance to erythropoietin by erythroid precursors, reduce iron intake, gastrointestinal iron absorption, and iron export into circulation by macrophages and enterocytes, reduced red blood cell half-life in the uremic milieu, bone marrow fibrosis associated with severe secondary hyperparathyroidism can lead to ineffective erythropoiesis. Routine evaluation of anemia to rule out other common causes, including iron, B12, and folate deficiencies, should be done. The diagnosis of anemia of CKD is a diagnosis of exclusion. Once the hemoglobin level drops to below 10 gram per deciliter and everything else has been corrected, erythropoiesis stimulating agents, abbreviated as ESA, may be administered. The use of ESA in patients with active malignancy or history of stroke or malignancy or severe hypertension should be avoided. Patients with advanced CKD may also have bleeding diathesis or a tendency for easy and prolonged bleeding due to problem with normal clotting. Contributing factors include platelet dysfunction inherent to uremia, reduced platelet aggregation due to the presence of various uremic toxins, concurrent anemia, abnormalities of von Willebrand factor and blood vessels that result in ineffective vasoconstriction. Corrective options include dialysis to remove uremic toxins, correction of anemia with the use of ESA to improve platelet aggregation, the use of DDAVP to induce rapid endothelial release of factor VIII and von Willebrand factor, the use of cryoprecipitate, which contains factors 8 and 13, von Willebrand factor, fibrinogen, and other clotting factors, or conjugated estrogen to improve coagulation. Acquired cystic kidney disease with increased risk for transformation to malignancy is a concern in patients with CKD, particularly those with advanced CKD and patients on chronic dialysis. Acquired cystic kidney disease, or ACKD, is defined as having greater than 3 to 5 macroscopic cysts in individuals without a hereditary cause of cystic disease. ACKD may occur prior to dialysis, but the prevalence of ACKD increases with advanced CKD and prolonged exposure to uremia. The pathogenesis of ACKD is likely multifactorial, but likely related to dysregulated proliferative changes associated with the loss of nephrons and genetic susceptibility. The key concern regarding ACKD in patients with CKD is the potential for malignant transformation to renal cell carcinoma. Management is obtaining surveillance imaging studies per symptoms and patient life expectancy. Any patient with CKD who presents with hematuria, flank pain, unexplained fevers, erythrocytosis, and/or unexplained worsening of blood pressure should be evaluated with a kidney ultrasound or CT urogram. Of interest, ACKD may regress to some degree following a successful kidney transplant. Depression is a common complication of CKD. Depression is the most common psychiatric disorder and is the most common psychiatric disorder requiring hospitalization in chronic dialysis patients. At-risk patients include patients of younger age and evidence of malnutrition, such as having low serum creatinine and albumin levels. Depression is not to be taken lightly because it has been shown to correlate with at least 30% increase in mortality. It has also been shown to be a risk factor for increased cardiovascular disease and mortality. Routine screening for depression is recommended at patients' first dialysis session, then biannually or more as needed. Psychiatric referral and use of antidepressants should be considered when depression is diagnosed. Malnutrition is a CKD complication that correlates with poor survival. Contributing factors include poor appetite, inappropriate protein restriction, increased inflammatory state, poor gastrointestinal absorption, increased albumin loss in patients who receive peritoneal dialysis, and inadequate dialysis therapy. Malnutrition adversely affects survival in patients with end-stage kidney disease or ESKD. Collaboration between a registered dietitian nutritionist and a physician or other providers such as a nurse practitioner or physician assistant to provide medical nutrition therapy is recommended. Protein supplements should also be considered. Given the multifaceted management of patients with CKD, the KDIGO 2024 guidelines combine slowing CKD progression strategies and improving both cardiovascular and overall outcomes into a holistic approach. The primary emphasis is on maintaining a healthy lifestyle. First-line drug therapy for most patients include the use of SGLT2 inhibitors, the use of RAS inhibitors as safely tolerated for blood pressure control, and the use of statins for modifications of cardiovascular risk. Targeted therapies for slowing CKD progression and managing CKD and cardiovascular complications are also outlined in this algorithm. Once end-stage kidney disease is reached, we can offer kidney replacement therapy to eligible candidates. At CKD stages 4 and 5, we can educate and discuss kidney replacement options. Options for kidney replacement therapy include in-center hemodialysis, where patients just go to a dialysis unit and get their regularly scheduled dialysis session, home hemodialysis, where patients self-perform hemodialysis at home, continuous ambulatory peritoneal dialysis, where patients self-perform peritoneal dialysis with manual exchanges of dialysate during waking hours or with the use of an automated cycler during sleeping hours, or kidney transplantation. In hemodialysis, blood is removed from the body and filtered through a synthetic biocompatible membrane in a device called a dialyzer or artificial kidney, where uremic solutes, toxins, and fluids can be removed. Electrolytes such as bicarbonate can be added to the blood as needed during this process. The clean blood, typically with added bicarbonate, is then returned to the patient. During hemodialysis, the patient is attached to the machine but is free to read, watch a movie, or sometimes just take a nap. Each dialysis procedure typically takes a little more than 3 hours. In peritoneal dialysis, the patient instills clean dialysate into the abdomen via a peritoneal dialysis catheter. The catheter is then capped. The dialysate is allowed to dwell in the abdomen for a few hours to allow for solute and fluid exchanges to occur across the patient's own peritoneal membrane. During each dialysate dwell, the patient is free to ambulate. After the dwell, the dirty dialysate gets drained and discarded. Dialysate installation and draining may be done by an automated cycler to allow patients to undergo peritoneal dialysis while sleeping. Each dialysis modality has its own advantages and disadvantages. In general, home hemodialysis and peritoneal dialysis require that patients are independent and can reliably perform their own treatments. Elderly fragile individuals or those who are unreliable with self-care should be referred to in-center hemodialysis, where hemodialysis is performed by trained nursing staff. Individuals who are good surgical candidates who can be reliable with self-care should also be referred to receive a kidney transplant, because having a successful kidney transplant can improve both quality of life and survival. On occasions when a patient runs out of vascular access to perform hemodialysis and peritoneal dialysis is not possible for whatever reason, referral to a transplant center may be considered for evaluation for a kidney transplant. At this time, you should be able to discuss the definition and staging of CKD, strategies to slow down CKD progression, CKD complications, and kidney replacement options. You should also be able to recognize and stage CKD, provide therapeutic options to slow down CKD progression, and manage CKD complications. Take great care of patients with CKD. Their long-term survival depends on our care.